You're listening to the Cancer Assist podcast, hosted by Dr. Bill Evans and brought to you by the Cancer Assistance Program. Wherever you are in your experience, we're here to provide help and hope as you navigate cancer prevention, treatment, and care. Help when you really need it.
Well, welcome to the Cancer Assistance Program's show with Dr. Bill Evans. That's me. And we are going to have an interesting conversation with Dr. Buddy Omar today. But before I introduce him, I just want to remind people of some of the services that the Cancer Assistance Program brings to residents in this area, receiving their care at the Juravinski Cancer Center or other institutions in Hamilton Health Sciences or St. Joseph's Healthcare, Hamilton. They include free rides to various medical appointments and to the cancer center. Also, loans of equipment like wheelchairs, ambulators, rollators, canes, commode chairs, access to some nutritional supports, to incontinence supplies, variety of different services, just to make the journey of cancer a little easier and keep people safe in their homes. And so these are all made possible by donations from people within our community, and we're grateful for them because the Cancer Assistance Program really does offer a lot of benefit to citizens who have a diagnosis of cancer in our region. So now I'd like to introduce Dr. Buddy Omar, and he's an assistant professor in neurosurgery at McMaster University and works at the Hamilton General Hospital, and he's also an associate member of the Department of Health, Research, Methods, Evidence, and Impact. That's a big title for a program, but we'll get into that. And he's got a research interest, which we'll explore as we go along in the program, in getting into administrative databases to find out some of the impacts on outcomes of the social determinants of health. So welcome, Buddy. It's really great to have a neurosurgeon. I don't think I've done a program about brain tumors and with a neurosurgeon before. And it's really a pleasure to have you with us. One of the things I'd like to start with is just you describing a bit your career, how you got to be a neurosurgeon. How did you get interested in medicine, perhaps to start, and then your training to become a neurosurgeon? Because I know it's a long training program to become a neurosurgeon.
Yeah, thanks, Bill, for having me. So for why I ended up becoming a neurosurgeon, it was a choice between being a brain surgeon or a rocket scientist, Bill. So I'm kidding. No, I think even in medical school, I was always interested in the brain.
Yes.
I was always interested in going into the neurosciences. Ultimately, it was a choice between surgery and neurology. I thought by being a surgeon, able to do more in terms of actually being able to deal with the lesions, and certainly the anatomy is fascinating. So that's really what lured me into neurological surgery. It's been great since. I've never regretted that decision.
You've had some specialty training along the way. You were out in Calgary, I gather, and it's called a skull-based surgery program. That sounds complicated to me as a medical oncologist, operating at the base of the skull where all the nerves come out and so on.
Yeah, so I've had at least 3 years of fellowship training, first in endoscopic skull-based surgery, effectively dealing with tumors that arise from the cranial, the base of the skull. So this would include pituitary tumors, and typically this would include surgeries where we go through the nose to access lesions at the base of the skull. So that's called endoscopic surgery. So that's one of my interests. The other being malignant brain tumors. So that's mostly the bulk of my practice now. So I've done training in that as well at the St. Mike's Hospital.
Right, in Toronto.
In downtown Toronto, yeah.
So there are a variety of brain tumors. They're not all the same.
Right.
I from my reading, I saw 100 types, or another reference at 150 types, I guess. Who's counting? But there are a lot of different types of brain tumors. And I think that's an important thing for people to recognize, that it isn't just one type of brain tumor or cancer. But for people who never really heard about brain tumors very much, a good place to start might be just, how would a person present? What kind of symptoms would they have that might alert their family physician to thinking that there's something wrong going on inside the skull.
Right. So to begin, Bill, you alluded to the variety of brain tumors. It's important to remember that brain tumors can either be benign or malignant, and in fact, it's a spectrum. So it's always anxiety-inducing when when you've been told or when you see an imaging result suggesting that you have a brain tumor in your head. But first things first, we need to differentiate between benign brain tumors and aggressive brain tumors, because the treatment and ultimately the prognosis would be very different.
Yes.
Right. So we can talk about that later. But as for what the presenting signs for, it depends on where the tumors are.
Right.
Patients typically present with gradually progressive neurologic deficits. This could include speech issues, problems with weakness on one side that's worse than the other, cognitive issues, again, depending on which part of the brain is involved or which part of the brain is compressed. Not uncommonly, we see brain tumors that are diagnosed incidentally, meaning we were doing a CT scan or an MRI to rule out a different a patient may come in with headaches and other non-specific symptoms, and we do a scan and find a brain tumor that's not necessarily causing the symptoms. So that's not uncommon as well.
Right.
So again, ultimately it depends on the size and the location of the tumor, and that would typically dictate how they would present.
I guess one of the common things would be headache, right?
Right, yeah.
Are there characteristics of a headache that might suggest more that it's a brain tumor versus a sinus headache or histamine headache?
So headaches typically occur when you have increased pressure in the brain. So remember, Bill, that the skull is a closed space.
Yes.
So brain tumor it's not something that's supposed to be there. So it would end up compressing the normal structures in the brain. So typical for tumor-related headaches would be headaches that are worse in the morning, headaches that are gradually progressive rather than acute in onset or something that comes in suddenly. And something that's really debilitating. Headaches that would wake up folks at night would be a particular red flag symptom. So those are things that would flag you towards thinking this might be a headache that would warrant further investigation.
So that leads logically to what is the further investigation? So someone has headaches and maybe fatigue and nausea and some neurological signs, something's not functioning normally.
Right.
How does a physician in the community proceed when they get a patient coming into their office?
So typically the physician would order imaging. So typically they would come into me with a cranial CT scan that's quickest to obtain. If there are abnormalities on the CT scan, then we would need a more detailed imaging modality that's typically done with an MRI. An MRI would give us more detail as to the consistency of the lesion, and it would be better in terms of giving us a presumptive diagnosis.
So are there features that you see on an MRI that suggest benign versus malignant?
Yeah, for sure. I don't want to go into technical details, but typically it would tell you if the tumor is arising out of the brain matter themselves, or is this tumor outside of the brain compressing brain. So the way I explain this to folks, I tell them, imagine the brain as a bowl of jello. There are two types of brain tumors. One type of brain tumors, they're like a piece of fruit, a piece of orange that's placed on top of the bowl of jello. So those are the extra-axial tumors we call in medicine, or the meningiomas, the benign brain tumors.
Yes.
So in those cases, you can actually take out the fruit, take out the tumor without damage to the underlying brain. The other type of brain tumor, they're more like food coloring or dye that's mixed in with the jello. So those are the intraaxial tumors. Those are the tumors that arise from the brain matter themselves. So when we talk about gliomas or glioblastomas, those are the food coloring kind of tumors. And when you give them the analogy, they sort of get a sense for what we're trying to accomplish when we're trying to do brain surgery. For the first one, for the fruit kind, you're able to completely take out the tumor. So they are tumors that are amenable to gross total resection. But for the second kind, for the food coloring kind, you just do a safe maximal resection. By definition, you're not able to take out all of the tumor out because of the infiltrating nature of the disease. Yeah.
So let's talk first a bit about the benign tumor, the fruit that's pressing in on the jello. I guess the most common type is a meningioma, which rises from the coverings over the brain, the dura mater. How do you get at it? You know, we've got a skull, a lot of bone there, and it sounds very scary to, I think, the average person to think about an operation on their brain, even for something that they've been told is benign. You mentioned already it's a scary thing to think about something expanding. It's affecting your brain and may interfere with how you think and feel and how you function, move your arms and legs. That's got to be one of the most frightening things that you can experience. So when you're going to access the area to try and remove this benign tumor, how do you do that?
Right. So to begin, Bill, the meningiomas are the most common intracranial tumors. And the reason why they're more common is that typically a lot of them are diagnosed incidentally. Again, we're doing CT scans or MRIs for other purposes, but we see meningiomas that are not necessarily causing issues, which is one thing I'd like to emphasize. Not all meningiomas need to be taken out, right? Again, these are slow-growing benign tumors, and there are features on imaging that are characteristic for meningiomas. So if they really do look like meningiomas and everybody's convinced that that's a presumptive diagnosis and it's not causing any symptoms on the patient, then there's room to wait. Right? I think that's one. I see maybe a third of my patients in the clinic, they come in with these reports with incidental meningiomas. And really, my job in clinic is to just reassure these folks that meningiomas are slow-growing benign tumors unless they're causing compression of the surrounding brain, unless they're causing symptoms. We might just need to watch them. So I think that's one takeaway point,
so
because these are
you just have them come back, and at intervals you'd have another CT scan to see if it's expanding and the rate of expansion and and
that's right, Bill. Yeah, so we'll do another MRI in a year just to see how it's behaving. Right. Some tumors, if they continue to show some growth and they're young, then maybe we'll need to consider trying to take them out. So the mainstay of treatment for meningiomas, it's surgical resection. Again, they're the fruit kind of brain tumors. So you can take out the fruit safely and completely without damaging the underlying jello, right? Unfortunately there's not a medicine. There's no medication that's able to melt the brain tumor. The mainstay of treatment for meningiomas really is surgery. And again, it depends on how big they are and if they're causing symptoms, whether we're indicated to treat. If they're in a place of the brain where they're accessible and it's safe to take them out, certainly we'll offer surgery. But in some cases, the risk of surgery may be too much. In that case, we might offer radiation treatment. So meningiomas are often radiosensitive as well. They don't really shrink the tumor, but they just keep the growth in check. Yeah, so that's another option for tumors that are in areas of the brain that might be too dangerous to get at. Yeah.
So maybe just explain. Perhaps this sounds a little gory detail, but how do you how do you get into the brain to operate?
Right. I didn't end up answering your question, Bill. So we do a craniotomy. Craniotomy is we use we take out the bone using drills, medical grade drills, and then we open the dura, which is the covering of the brain, and then carefully under direct visualization, we, especially for the tumors that present to the surface, we would try to create a plane between the tumor and the surrounding brain. For the fruit kind of fruit kind of tumors, the meningioma or the extraaxial tumors, you're typically able to distinctly see where brain begins and where tumor begins. You're able to see that, and essentially the idea is to be able to take out tumor with minimal injury to the surrounding brain. So we have many techniques to do that as safely as possible for us. So again, it depends on where they are and how frail or how healthy the patients are preoperatively. But for most of them, they're able to go home from hospital in 1 or 2 days and go back to their normal daily activities in 4 to 6 weeks. It's different for different folks, but that's the median number. Yeah.
And for the meningioma, which we said was the commonest benign, do we know why they occur? Is there anything that in the environment or anything that's associated with the development of meningiomas?
Right. It's a very good question, Bill. It certainly has nothing to do with diet. Certainly has nothing to do with whether or not you get exercise. Certainly has nothing to do with whether or not you smoke.
These are all the things that are associated with a lot of other cancers, but not with
these.
Right.
So not associated with the traditional cancer risk factors.
Yes.
The only known risk factor for meningiomas that's been documented is a history of ionizing radiation. Oh, okay. So for instance, if you had radiation as a child for other cancers, you can get radiation-induced meningiomas later on in life.
That's very interesting because I have a godchild who had acute leukemia when she was 3 or 4 years of age, and she did develop a meningioma.
Right.
I hadn't made that association, so but she got whole brain radiation as part of her treatment for her leukemia.
Right.
That's
not uncommon. But again, if the meningiomas are not causing any symptoms, if they're incidentally diagnosed, I would presume that in your daughter's case that might be the case. They just wanted to do surveillance imaging. If it's not causing any symptoms, we just need to keep a close eye on them.
Yes.
Now,
if you do the surgery, what's the downside of it? If you're trying to separate this benign tumor, but it's pressing on the brain, and you're relieving the pressure, is there a risk of adverse events occurring after the surgery?
Right. So there's always risk to any medical intervention, Bill. For the craniotomies, I would typically quote a 5% risk, 4 to 5% risk of serious life-threatening complications, including severe disability. But take the reverse of that, 95 to 96% chance that you won't be dealing with those serious issues. The risk for minor complications a little higher, up to 10 to 12%. So this could include things like infections, which is a risk present with any surgical procedure. Things like post-operative bleeding that can cause transient new deficits that hopefully improve in the longer term. Right? The chances for these deficits becoming severe and permanent would fall within the smaller 4% to 5% risk. So certainly when we make the decision to proceed with surgery, we don't make that decision lightly. We have to make sure that the benefits of surgical resection outweigh these risks. And these are decisions we make together with the patients and their family members. Yeah.
What about the risk of seizures after surgery?
Yeah. That's also been documented, Bill. So that's part of the 10 to 12% non-life-threatening risks. There's also a quite uncommon, but it's been documented, the risk of status epilepticus or seizures that are prolonged and would cause altered level of consciousness in patients, especially for when we're dealing with the more aggressive brain tumors. The risk of that is small. It would fall within the lower 4% to 5% risk. Yeah.
Now, in terms of the other benign tumors, and you mentioned this approach through the nose, those would be for things like a pituitary adenoma or craniopharyngioma?
You got it, Bill. So these tumors occur in the base of the skull. Mm-hmm. So if you look at a side view picture, a sagittal cut of the brain, you will find that you can actually reach the base of the skull through the nasal cavity. So the neurosurgeons have developed a way to go through. It's actually been developed in the early 20th century, going through the base of the skull through an endoscope that's placed through the nose, and that would allow us to take out the tumor through a more minimally invasive, a less invasive approach. Because the alternative would be to do a huge craniotomy to get at the base of the skull.
I think most people would have a difficulty imagining how you see what you're doing with a scope up through the nose and through through the sinus passage into either the pituitary space or above that to a craniopharyngioma. So you're operating kind of like way they would do abdominal surgery, I guess, with minimally invasive approaches with a camera, and you're seeing a TV screen and manipulating things, small instruments going up.
Yeah.
It sounds very delicate and very dangerous because there's a lot of structures in there.
Yeah. You got it, Bill. It's advances in optics and advances in technology that have allowed us to do this safely. It's been developed early in the 20th century. It's been abandoned just because it was very difficult. But now that we have better instruments, we're now able to carry them out safely and effectively. So typically, it's done with a neurosurgeon working with an access surgeon, typically an ENT specialist.
Okay.
So it's a two-man operation. Or two-person operation.
Yeah, we have to say two-person these
course.
days because
Yeah.
there's so many ladies in
Which is important.
medicine and surgery these days.
Yeah.
Right?
I've worked with many female colleagues who are incredible. Yeah.
So those are three of the benign tumors. I guess, is there one other thing, the schwannoma, which is or acoustic neuroma is another benign tumor. And I'm interested to know how you attack those, because that's from the eighth cranial nerve.
Yeah. So the acoustic schwannomas is another benign brain tumor. They arise out of the covering or the nerve sheath that surrounds the eighth cranial nerve, which is involved in balance and in hearing. You can get at it using a retrosigmoid approach. So we go through the back of the brain. You need to retract the cerebellum, and that would expose the area where you can get at it. An alternative way would be to go through the ear. It's called a translabyrinthine approach, and you do that with our ENT colleagues as well. So many ways of doing this to be able to do this safely and effectively for our patients. Yeah.
It sounds like very delicate surgery because a little slip could cost a person their hearing, or when you're doing the one through the nose, the optic nerves are running very close and cross there. So many things. Does robotic surgery figure at all in neurosurgery these days?
So it's not ready for prime time yet, but certainly that's been explored more in the investigational realm. We've read about robots that are able to do the opening for us in translabyrinthine approaches to take out the acoustic schwannomas that you described, Bill. So typically we don't use the robots yet, but who knows what the next few years will hold for us. Yeah.
The other thing I always thought about neurosurgery is these are very long procedures. Give us some idea of the length of time to do some of these operations.
Not necessarily, Bill. For craniotomy, for supratentorial tumors, for tumors that are in the cortex and presenting to the periphery, surgery could take 2 to 3 hours. For the more complex skull-based operations, it can be all-day affairs.
Yes,
but
that's what I was thinking.
Right. Yeah. But again, we've gotten much more efficient. We have better tools now that are able to help us in achieving this and being able to complete surgeries quicker. So
an all-day surgery. What about the surgeon's nutrition and bio breaks and things?
Right. That's why you need training, right? Years and years of training to be able to
last that long.
Right.
Because you can't easily just stop and walk out and scrub out of the procedure and come back in a few minutes. Yeah. Very fascinating. Look, we're going to take a brief break here and have a word from the Cancer Assistance Program itself, and then we'll be back with Buddy Omar to talk further about now the malignant brain tumors and how they're managed, and also on Dr. Omar's research interests. We'll be right back.
We'd like to take a moment to thank our generous supporters, the Hutton Family Fund and Banco Creative Studio, who make the Cancer Assist podcast possible. The Cancer Assistance Program is as busy as ever, providing essential support to patients and their families. We remain committed to providing free services for patients in our community, including transportation and equipment loans, personal care and comfort items, parking, and practical education. These services are made possible by the generosity of our donors through one-time gifts, monthly donations, third-party fundraising, corporate sponsorships, and volunteer opportunities. Visit cancerassist.ca to see how you can make a difference in the lives of cancer patients and their families.
We're back talking to Dr. Buddy Omar about brain tumors, and we talked about benign brain tumors in the first half. We're going to talk about the malignant ones, the dye in the jello,
Right.
so to speak. So these are more challenging because they're infiltrating the normal brain tissue, and it's like the dye. You can't really see a distinct margin, I guess, is part of the issue. So talk a little bit first about how they're diagnosed.
Right.
Is it any different in terms of the techniques of making a diagnosis or both on the imaging and also actually getting tissue to confirm that it's truly a malignant brain tumor?
Right. So thanks for that question, Bill. So these malignant brain tumors, the most common one is called glioblastoma, as you know. There are certain imaging features on the MRI that would suggest an infiltrating, aggressive malignant brain tumor. But to clinch the diagnosis, just because it's such a grave diagnosis, just because it's just a serious diagnosis, we need to get tissue, right? Yes. Because with just the MRI, all you have is an educated guess. The way we treat these aggressive brain tumors is to try to take out as much of the tumor as we can. So we try to aim for a safe maximal resection. And that would accomplish many things. Number one, it gives us the tissue diagnosis that would guide further treatment. It would also allow us to improve survival, right? Trying to take out as much of the tumor that's been proven to prolong survival. And also, when we're able to take as much of the tumor as we can, we're able to improve the swelling around it and hopefully improve symptoms, although that's not a guarantee. But certainly it also allows us to reduce the need for patients to be on high doses of steroids, which has a long list of side effects itself, right? Mm-hmm. So that's the goal. Unfortunately, with these aggressive brain tumors, Bill, we haven't figured out the way to completely cure the disease, but we do have ways to prolong survival. Again, surgery is one of them. But because, again, it's going back to that food coloring analogy, we're even when we're able to take out everything that lights up on the MRI, by definition, we're not able to take out all of the cells, right? It's, again, we're not able to take out all of the food coloring that's mixed in with the jello. What we can do is take out what looks abnormal. And that's why they need more in terms of treatment, and that's typically a combination of chemotherapy and radiation treatment. So the first line treatment is something called the STOOP protocol.
What protocol?
The STOOP protocol, STUPP.
Okay.
It's named after Roger Stoop, which led the seminal study on this. So it's giving patients temozolomide. It's just a tablet they take, along with radiation, and that's what we offer.
So get the two together, the radiation while they're taking the tablet of the chemotherapy drug.
And we give them together because they have synergistic effects. Right. And those are given by our medical oncology or neuro-oncology colleagues, along with the radiation treatment specialists as well. So, Bill, it goes to this concept of neuro-oncology being a team sport.
Yes.
So I work closely with my neuro-oncology and radiation oncology partners. We talk about what the next best step is in weekly brain tumor boards, because what the best treatment strategy for an individual might differ. So there are lots of nuances to the treatment of brain tumors after surgery.
Well, this is important for patients to know that it isn't just, your decision that independently you think it's best to do this operation, but you don't think you want to do radiation or chemo because that'd be upsetting. But there's actually a group of people experienced who are talking about individual cases, and collectively they're arriving at a recommendation what's best for the patient. Yes. I think that's, to me, is a reassuring thing for patients to know that it's the decision isn't resting on one person's experience and knowledge, but on really a group of experienced and knowledgeable specialist in that area. Now, the glioblastoma, there's sort of a spectrum of glial tumors. There's some that are more benign, and then like an astrocytoma, and then you have the glioblastoma multiforme, so-called, which is a very vascular tumor. I'm sure that operating on some types is easier than others. The glioblastoma multiforme, because it's so vascular, must be a very challenging operation.
Yeah, I mean it's so different. We do use different techniques for different tumors. I wouldn't say glioblastomas are more challenging. I would actually say low grade tumors, if they're in areas of their brain that are if they're sat near the speech areas, for instance, or if they're sat near the areas of the brain that are responsible for strength. It's really not necessarily the pathology. It's more the location, Bill.
Okay.
And maybe the size of the tumor. So yeah, you can have low-grade tumors that are trickier to take out than the higher-grade tumors.
Okay.
Just because of where they're located.
Okay.
Yeah.
And to protect things like speech, I gather some of these operations are done with the patient conscious, and you're able to identify by asking the patient whether you're getting into an area that would affect their ability to continue to have speech.
So the central challenge in my line of work, Bill, is trying to balance my desire to take out as much of the tumor as possible. So balancing safe maximal resection against trying to maintain patients' functional outcomes or improving functional outcomes. But we have adjuncts now that help us make the surgery as safe as possible for us. So over the general, for instance, I work with a scientist at St. Joe's, a neuroscientist who does functional MRIs. So the functional MRIs are like the routine MRIs, but she has special techniques that allow us to be able to pinpoint exactly where the functional areas are in the brain, and to determine where these functional areas are in relation to the tumor. So that allows me to be able to plan the surgery more safely for our patients. So that's one thing we do. It's the functional MRI. We also have, as you said, we're able to do awake craniotomies now.
Sounds strange.
It sounds strange, but we've been doing this for a while, and it's been very helpful for our patients. And during awake craniotomy, it's funny, Bill, the brain itself is insensate, so you can touch the brain and you won't feel anything.
Yeah.
It's the structures around the brain that are pain sensitive, so the skin, the muscle, the bones. But those are numbed during the surgery, so you shouldn't feel uncomfortable. And so they're kept awake because that allows us to be able to localize exactly where the functional areas are in the brain. Where's the speech area? Where's the motor? Where the motor areas? So it allows us to do intraoperative stimulation. We apply low voltage electric current to the brain, and then see how that interferes with function. And then you're able to know exactly where the functional areas are to be able to avoid them. It's like being able. It's like driving with the Google Maps on. You have real time feedback to know that you're
Sorry, another good analogy.
Right? You're not near the highway that you don't want to block, right? So you're able to do this as safely as possible, and you also have it allows you to be more aggressive with your resection because you have real time feedback. You're seeing that you're not hurting patients, so you're more able to take out. You end up taking out more tumor. Is what the studies
Which is what you want to do,
right?
because I guess the larger the resection, the
Right.
more space you're creating, so that, as you say, you may not be able to take it all, but if it grows back, it takes longer to fill that space and produce symptoms again.
Right.
So.
Yeah, exactly. You got that correct, Bill. So the studies have shown that the extent of resection matters. The more tumor you're able to take out, the better they do in the longer term. And that realization has not been. It's neurosurgeons didn't always believe that. In the early part of the 20th century, neurosurgeons were very aggressive. The pioneers even did hemispherectomies for brain cancer. So taking out the whole half of the brain, even doing that did not cure the disease. So that sort of tempered their initial enthusiasm. But now the paradigm has shifted back. Now with better quality studies, we know that the extent of resection actually matters. But the caveat being, you should be able to do this safely, because if you cause new functional deficits, then you actually are not able to prolong survival. You do the opposite.
Yeah.
Right? So technical expertise matters in terms of achieving good oncologic outcomes in brain tumors.
Well, it sounds like things have changed quite a bit since I was a trainee at Princess Margaret Hospital. Actually, one of the things I had to do during that training was to review 100 charts of patients who had glioblastoma multiforme. And it was very predictable back then that, they'd have their surgical resection as much as the surgeon could do at that time. Then they'd come for their radiation, and then they'd be followed. And generally, after 3 months, they weren't followed again because their tumor had recurred and they passed away. The one single exception was a person who actually had a tumor in their temporal lobe, and it was possible to resect the whole of the whole lobe, and they had long survival. So rarely, but nonetheless, it happens that patients can be cured of even an aggressive brain tumor. But other treatments are starting to emerge too, partly because we're understanding a little better, I think, the genetics of these tumors, and finding it's kind of like repeating the history I had in lung cancer, where initially it was all one lung cancer, then it became a couple of types defined by microscopy. And now it's, you can define it by genetic mutations.
Right.
And so some of that's creeping into the neurosurgical area as well, I believe.
I would say this, Bill. We can still do better than the standards 2 protocol we have now, and that's been the subject of intense research. I think in the future the buzzword would be personalized medicine.
Yes.
We give these tumors a single name. We all call them glioblastoma, but in reality they're really very different tumors from each other. We have ways. We have certain molecular markers that help us know whether these tumors are susceptible to chemotherapy. But at this point, Bill, we're very limited in our ability to tailor the chemotherapeutic regimen we have based on those molecular markers. So we can certainly do better in terms of future drug discovery for GBMs. And I think in the future that would be the trend would be to try and understand the individual tumor and to treat the individual tumor, because I don't think I don't think one size fits all for GBM.
We're certainly learning that over and over again in all the other tumors of the body. So it would be surprising if it didn't apply to brain tumors as well. So it seems like a very fertile area for research.
Right. But as you know, Bill, the brain cancers are trickier because our anatomy protects.
Protects the brain, so it's hard to access.
Right. So there's this thing called the blood-brain barrier that prevents most of the chemotherapeutic agents that we have available for other diseases from even entering and accessing the tumor in the brain. Right. It's helped us evolutionarily, but it's not in the case of
not helping us treat them
for sure
for the malignancy, because we don't have sort of the equivalent blood-brain barrier in a lung cancer or breast cancer, so it makes it easier to treat. So you brought up a topic of research, and I know you're very involved in research and also working with ICES, which is you can remind me what the acronym stands for, but it has a huge databases that you can mine about patients' illnesses and resources used to treat them. But you're particularly interested in the social determinants of health, I think. So how does that factor in to brain tumors?
Right. So I've been in practice for a while now, Bill, and what I've realized is that what happens in the operating room, what happens in the hospitals during chemotherapy and radiation treatment, they're not the only things that matter in terms of outcomes. So socioeconomic factors, where folks live, their educational status, their ability to access healthcare, those are also very important determinants of how they do from their disease in the long term. It's cancer health disparities have been described for other diseases like lung and breast cancer, but these are screen detectable cancers. So you sort of understand how cancer health disparities could exist for these specific cancers. I was wondering whether it did exist for a high mortality and for such a fast-growing cancer such as GBM. So that was the whole impetus of that study, because if we needed to see if those cancer health disparities exist before we can begin improving them. We were not able to improve what we're not able to measure. So that was the impetus for the study. So we were able to do this through ICES. It was, I think it's just called ICES now, Bill.
We used to call it ISIS, but that wasn't a good idea any longer.
Previously, I think it stood for Institute for Clinical Evaluated Sciences, whereas now it's just ICS. So all when you're admitted to a hospital, when you get treatment, when you get radiation, or when you get when you consult to the emergency room. All these visits are recorded in routine administrative databases. They were not specifically made for research, but now we have tools that allow us to be able to rigorously use these resources to answer questions in health services and comparative outcomes research. So in this particular study, we're able to look at the outcomes for more than 7,000 patients with GBM that were treated in the province for over 15 years. And we were looking at where the patients lived, whether they were immigrants or not, whether they lived in a rural or urban center, whether those affected survival from GBM. And it was quite glaring and it was quite surprising that cancer health disparities do exist. So folks who lived in quote-unquote more deprived neighborhoods, poorer neighborhoods, they had a 17% increased hazards of dying from GBM compared to folks in the least deprived neighborhoods. So that was glaring to me, because we have a universal healthcare system.
Yes.
Right.
And we'd like to think that everybody can access it equitably.
Yeah. And more, another glaring thing we found was that folks living in the most deprived neighborhoods, they had 26% decreased odds of getting required chemotherapy and radiation within 6 months, compared to those in the least deprived neighborhoods. So just knowing these cancer health disparities exist is important. It's the first step, but of course we need to understand the mechanisms. Why does this occur in the first place? Because this is something that we can address now. It's important to look for new drugs, and we have folks that are much smarter than I am, trying to figure out newer medication for glioblastomas. But equally important for us to address these gaps. We need to understand why some folks in more marginalized populations, why the outcomes are worse for them. Because we can do something about that now. We don't need to wait on these studies and we don't need to wait on newer drugs to improve their outcomes. We need to improve their access to the drugs that we have available now, right? Which I think is equally important.
That's an impressive statistic that such a proportion of individuals from those neighborhoods, shall we say, are not accessing the therapies that we know work to a degree. And so understanding the why must be part of the next
for sure, Bill.
research.
Right.
Why are they not? And does it come down to things like lack of awareness or lack of willingness or fatalistic attitude toward illness, or even affordability to, I used to, when I was directing the cancer center, hear that women wouldn't go to mammography for screening because they couldn't afford the price of a bus ticket. Those things which seem trivial to many of us are actually important barriers to people. So understanding why these folks aren't accessing the care that would benefit them would be important to try and understand.
For sure, Bill. And it's just the first step. We need to understand the mechanisms. What would explain this patterns that were quite surprising. The costs for radiation and the costs for chemotherapy are covered by government mostly. But there are out-of-pocket costs as well, right? Going to the hospital, whether or not they can afford to take paid sick leaves. These all come into play in terms of access to treatment. We also looked at whether or not being an immigrant was associated with worse overall survival. We saw an interesting thing though. Immigrants, long-term and recent immigrants, actually did better in terms of overall survival versus non-immigrants, and that has something to do with how we choose our immigrants, right? Because they're the
More affluent, perhaps?
it's called the healthy immigrant effect. So we
Yes.
select immigrants based on their educational level. So again, that goes to show it's likely health-seeking behavior that's in play here. We did not see this effect for refugees because refugees are chosen by a different set of criteria. So while economic immigrants did better than non-immigrants, there was no significant difference between refugees and non-immigrants.
Isn't that fascinating?
Right.
Well, it speaks to the benefits of, I guess, getting a good education and a good job in life can give you money that allows you access to a variety of things, including better health care in a way, or at least being aware of better health care so that you can access it. And overcoming some of these benefits. We've actually done a podcast with Dr. Chris Longo, who researches about the out-of-pocket costs. And when we talk about universal health care, some people would assume that everything's covered, but there are a lot of things that are not. And he has identified that monthly costs are in excess of $1,000 now. So that's a significant barrier for many in our society. So important barrier to try and overcome. And it also underscores the value of supportive care programs and charities such as the Cancer Assistance Program. We can get patients to and from the hospital at no charge. We can lend them a wheelchair or other access devices that would cost really a lot of money if you were to buy it personally, but it can be loaned to them free of charge through CAP. So it's important that people even be aware that those services exist, and that in itself is a bit of a challenge and a potential benefit of this podcast to make people more aware that those services are available to them. So anyway, this has been really sort of mind-expanding, if we can sort of play on the words of we're talking about the brain and brain cancers. Are there any final thoughts you'd like to leave our listeners with?
Well, I'd like to summarize what we've discussed here, Bill. So first of all, brain tumors, they come in, and they're a heterogeneous group of tumors.
So there's a lot of different types.
For sure, yeah. You can have benign tumors and malignant tumors, and they would require very different approaches to treatment. Again, not all brain tumors need to be treated at all. If you have a benign brain tumor that's not causing anything, we just need to keep a close eye on this. I like to go back to this take-home message because, again, I see a lot of these patients in clinic, and all I try to do in these visits is to just reassure them that sometimes incidental benign brain tumors, we don't need to do anything about them. On the other end of the spectrum, you have aggressive brain tumors that, again, we do have ways to prolong survival, even when we're not able to achieve cure for aggressive brain tumors. We have surgery, and as well as chemo and radiation treatment. A team of multidisciplinary team of physicians would be the best way to achieve the best outcomes for these patients. And also, Bill, important to remember that more than the type of surgery they get, more than the chemotherapy and the radiation treatment that they get, other factors outside of the hospital also play a role in terms of outcomes, and we need to address these as well. So focusing on marginalized populations, looking at folks that are quote-unquote high risk in terms of treatment abandonment, high risk in terms of their socioeconomic status, empowering these marginalized populations, that's also important because that allows us to reduce the inequities that we see in outcomes from GBM treatment in the province.
Well, that's a wonderful summary of what we've been talking about. A great conversation, and quite illuminating to me, and I hope to our listeners. I'm sure it has been, because this isn't a topic that we've discussed on our podcast before, but obviously a very important one for the people who are affected by brain tumors, be they benign or malignant. So I really want to thank you for your time and for participating in this podcast. Buddy, it's been great talking with you. Thank you.
Thanks for having me, Bill.
You're listening to the Cancer Assist podcast, hosted by Dr. Bill Evans and brought to you by the Cancer Assistance Program. Wherever you are in your experience, we're here to provide help and hope as you navigate cancer prevention, treatment, and care. Help when you really need it.